Hello and welcome to the New York State Care Management Training Initiative. My name is Ruth Colon Wagner, and I am the Senior Project Coordinator with NIAPRS, the New York Association of Psychiatric Rehabilitation Services. NIAPRS, along with our partners, we welcome you here today to the statewide Learning Collaborative for webinar number 3, Navigating Multiple Systems and Collaborating with Others. I'd like to introduce you to our presenters today. Peter Baumann is a social worker, and he is the Senior Project Manager for the Finger Lakes Performing Provider Systems, and that is one of the new district initiatives in that region. Prior to that, he was Manager of Population Health with MVP Healthcare, and also has over 10 years' experience as a therapist. Peter presented webinar number 3 in this series and is back today for this Learning Collaborative. Next, I'd like to introduce Paul Margulies. He is the Associate Director for Practice Innovation and Implementation for the Center for Practice Innovation. He is a licensed psychologist and has a long history as a provider and in academia. He is a font of knowledge, and we welcome him and Peter here today. And tirelessly working in the background is Nancy Covell of the Center for Practice Innovation and Diana and Cheryl from the New York Care Coordination Program. So we thank you for joining us today, and we'll begin our Learning Collaborative statewide webinar with Paul.
Thank you so much, Ruth, and I'm going to begin by showing the agenda. And there are 3 major topics that we're going to be talking about today. The first is collaborating with medical providers, and we're going to talk about how to do it and how to supervise. The second is hospital collaboration. Same story, how to do it and how to supervise. And finally, collaborating with managed care organizations and how to do this and how to supervise. And the way in which we've structured this webinar is it's designed to be very interactive. So as folks will see, and we're going to begin in just a moment or so, there are a number of polling questions, and we'd ask that folks respond to the polling questions as a way of sharing from your experiences with one another. And what Peter and I will do is we will be responding to your, to the points that you're making, as well as presenting some additional information. So, collaboration with medical providers. Let's begin with our first polling question. And as you can see, what we're asking you is, how do your care managers currently interact with medical providers? What do they do very concretely in their work with medical providers? We're going to give you a couple of minutes to respond, and the way in which to respond is with the chat box, which you see on your screen. We'll give folks a couple of minutes, and then we'll see what they have to say.
And I guess what I would say to that, Paul, just joining in here, this is Peter. Welcome to all of you. As we're getting questions in, I think the key thing to remember is the interactive process, and that we really want to use this as an opportunity to be helpful to your colleagues and to you, and really beginning to assess the coordination and the ask of what it means to be a health home provider, which is quite important. So as those come in, we'll hopefully give you a couple of things to do with your peers and start integrating this, as a lot of you have in some of your teams.
Good points, Peter. Thank you. Just waiting for folks to respond. Okay, Peter, I'm beginning to see some responses, so let me begin to read them.
Great.
And what we're seeing is regular phone contact and face-to-face meetings, Care managers call medical providers to coordinate care but struggle to get in touch with anyone. Telephone, face-to-face, introduce the service, explain functional plus for PCP and patient, underscore tenets of health home. Some more notes, letters identifying self and the role and requesting information exchange, phone calls, direct visits with clients, phone contacts, accompanying clients to important appointments, faxing consents, faxing and mailing care plans, checking on patient portals with consent with individuals for updates from providers.
Well, that's great information, Paul, and I think great stuff to bring to the table. And, you know, as we were well aware, you guys are ahead of the curve on a lot of these issues. But if we go to the next slide, we can look at maybe some questions that you want to ask or bring up in team meetings in regards to, you know, how are we interacting and are we doing it in a way that's helpful? So, some questions to think about. When you're looking at medical provider collaboration, you want to know who's involved, what are their roles, and how much contact do you have with them. And I think that it's important here just to know what is working and what is not working. And so I think, you know, one of the things that we wanted to do, if we go back a slide there, Paul, we were going to get at sort of some what works and what doesn't work for the providers.
Yes. So the question is, what's going well and what challenges are people facing? I'll give folks a couple of minutes to respond to this one.
Sounds good. And I think as we go through the presentation, some ideas that I wanted to run by folks or think about when it comes to medical providers is think of two things. Folks are essentially on two paths. Either they're really well connected to a provider, and maybe they need some assistance with how to prepare and utilize that relationship in a way that's meaningful to them. And secondly, maybe they have no provider. They really identify nobody as a medical provider. Possibly they use the ER for their ongoing services, or the emergency room or emergency department. Or they might go to a neighborhood clinic where really they don't consider that a medical situation. They see it more as a place that they go to get their needs met and some social needs met as well. So as we go through the first portion of this presentation, we can give you some things to think about for individuals that identify a provider and those that don't.
Thank you, Peter. And I'm looking and I see some responses here, so let me begin to read them. What's going well? Community connections. More providers over time are understanding the care manager's role and the advantage to their patients in practice. Now, that's really cool.
Absolutely.
That's good to hear. There's good collaboration, someone tells us. The PCPs are happy for patient support, coordination with the medical home, discharge planning, face-to-face in hospitals. So lots of good stuff here. See what else we have here. And I also have some challenges somebody has typed up, so I'll read some of those. Referrals to specialists seem to take a long time. The client PCP relationships are not necessarily one of trust. Here's another positive. There's a good response to letters requesting supporting documentation. That's a good thing. We're building some relationships with those providers used most by our clients. We're developing relationships with providers outside of our county. We were lucky to find a provider who, quote unquote, gets us. This is good. She welcomed us being at the appointment. Hospitals seem to respond to better for transitional care plans. So these are positives.
Great.
We are learning that the health home is the boss. We have to do what they say and respond to them. What our in-house are not always lined up. What our in-house goals are not always lined up with the health home goals. So that's an interesting observation. Another positive, providers are open to having care managers in their practices, some time to learn more and generate collaborative referrals. Medical providers are happy to have someone to contact for clients they care for if they are concerned about the client's ability to follow up. Interactions with office staff are good. Recruiting is getting smoother. Okay, here are some more challenges. Some providers don't return calls or feel inclined to participate with service provision. So despite all of the outreach, some people just aren't on board yet. We've attempted to schedule meetings with medical providers to present our health home care management program, but again, to struggle to get our phone calls returned. Time is always a factor. Many of the medical practices remain siloed, unfortunately. Identifying medical recipients who are willing to be responsive, engage with the client and collaborators. Referrals for Medicaid transportation are not completed. Providers are not on the same EMR systems. That's big. It becomes very inefficient to fax care plans, getting put on hold, all that kind of stuff. There's an issue, one person's reporting about the availability of the PCPs, the primary care providers. A refusal to see clients based on 2 no-shows or a lack of a copay. Prescribing psychiatric meds to clients without consulting outpatient mental health provider. Wow, that's a whole other set of issues. And then, let's see, a couple of other notes here. Caseload size does not allow attending some appointments that are important. Care plan is evolving and hard to know when to distribute as it is often changing. Not getting clear goals from other medical providers. And then somebody, and we do hear this a lot, just trying to keep up with the workload isn't an easy thing. And then on the other side, the providers are so busy and they have a time limit on the time they can spend with a patient. And we use up some of their extra time. And then I'm seeing a number of comments here that are kind of repeats of things we've already said. So is there anything else new here? Here's one. Multiple medical providers and the need to coordinate, especially if the client goes to the hospital emergency room often for services. And another issue, somebody identified that several MCOs are hesitant to share information, even with proper releases. So that's the story. It sounds like in some ways there's been a fair amount of progress being done with certain medical providers. In other ways, though, there continue to be some issues with others. Yeah,
and that's great. And so I think that we can address some of the issues here throughout the presentation, because we do spend some time towards the end of the presentation and talk about how MCOs really interface and maybe some of the hospitals and how we can make that relationship better. So let's kind of go to the next slide here. I started to run down some of these questions. And let's look at, again, 2 things, just to give folks context. Individuals that identify a provider. So let's look at that. How can you do that? And I would think, is this part of your status or supervision or team reviews when you're struggling maybe, or there's an individual with multiple complex needs, as I'm sure all of you are aware. You have, a whole array of cases and needs, and if you're quote-unquote stuck, these might be some good questions to ask around the medical issues that are going on. Have you asked the individual you're working with, Where do they receive the medical care? How would they describe their relationship? What would they change? How has their medical provider helped them in the past? What you're getting at here is intensity. How, they can have somebody listed as their primary care physician on their Medicaid card or their managed care card, but you know what? That might not be the person that they go to. It might be a cardiologist that they really trust. It might be a nutritionist. So it's really getting a sense of what the individual believes or where they receive their medical services. Are they happy? Think of customer service. I think a lot of times we naturally, reflectively want to, quote unquote, solve issues for individuals. But take it from a customer service perspective. When you're seeing how someone feels about their services, you ask them, what would they change? What do they need out of their provider? Because all that is going to do is give you information if they're not happy with their current circumstances, or maybe they are happy. You're getting a sense of how often the individual acts with their current provider, but also giving you an indication if they're unhappy, what they need from a medical provider. So next slide, Paul, please. Okay. And again, this is another question that you might want to ask the consumer, individual that you're working with. If they had a question regarding their medical concerns, who would they call? Again, what this goes back to for me is, who can you call when you have an issue? And what I mean by that is you're getting back to the relationship issue with the individual. Can you go to the next slide, please? Now, someone had brought up, I thought I heard this, Paul, when I was writing down some of the responses, that access was an issue and folks might be too busy. They don't understand. So I think one of the things that you can always do, and think about this in terms of your own work, is go to the provider if you're having trouble getting in touch with them and ask them, how can I help you? Instead of going with needs, I think we need to let practices know these are some things that I can do for you. So when you're working with your colleagues and your peers, I heard a couple of good strategies of reaching out to medical providers. Maybe it's just having a fact sheet or speaking to office staff, RN, anybody that's willing to have a conversation. Is your team talking about how you can assist them? And some key words that I would suggest that you might want to talk about is you have information. You have information on what's going on. So a lot of folks have different medications. A lot of folks have a lot of visits or circumstances outside of the medical provider has 20 to 30 minutes if you're lucky with that individual. You can provide them with a lot of information and support. And let's say the medical provider needs help with them getting to a specialist or getting them into a level of care that's important to them. Again, what is your value add when you go into these provider offices? Because you have a lot to offer and to support their goal and their mission within their practice. So if you're getting some feedback that they don't have time, you know what? Make the sale. That might be a way to think about it because you have a lot to offer them. Next slide. So let's say the individual doesn't have a provider. We can go into some of the questions that we can ask there on the next slide. If an individual doesn't have a provider, why is that? What's the barrier? What's getting in the way? Do they see no benefit to having a provider? Is it a transportation issue? Is it, they've had poor experiences in the past? That's some stuff that you want to get down to for them. How can you link them to a provider? Someplace close. What do they need? Some of the questions. And I think lastly, what we want to get to is a lot of people might be intimidated with, meeting with a medical provider or primary care physician. Let's prepare them for the initial visit. Do you have maybe a tool or a resource? I know that at the previous webinar, there's a ton out there to help prepare folks for an initial visit. So just some thoughts about medical provider collaboration, and I think, Paul, we have some poll questions following that.
Yes, thank you so much, Peter. So here's our next poll question, folks, and it is, how do you currently supervise care managers' interactions with medical providers? What can others learn from your efforts? Please give us some examples. So this is about your work as a supervisor and how you're working with your care managers specifically around their interactions with medical providers. So we're going to give you a couple of minutes. Please type up your answers, and we'll do some sharing. Thank you.
As these are typing up, Paul, I guess one of the things that I also hear, again, I was writing some of these responses, and someone had mentioned no-shows. And I think one of the ways that you can help somebody, again, that you're maybe statusing or supervising with, is really get at people don't show for a reason. So you have to initially figure out what is it? Is it a more specific, I can't get there, I'm working, and can't find the time, transportation, those sort of issues you can address on some level with that interaction. But then if they continue to no-show, there might be something else going on there. So I would ask for questions of the individual about, do you see no benefits to interacting with a provider? Is there some trepidation, or you don't feel like you're going to get anything out of it? So it's really trying to provide some good assessment questions for the care managers in these interactions that they're having with individuals. Because there's a reason why people are no-showing. And if people really thought there was a true benefit, I've found that they'll find a way to get there.
Good point, Peter. So let me read some of the responses.
Great.
So I might ask as a supervisor, have you made the initial phone call to introduce yourself as the health home care manager? Have you followed up with sending out an intro letter and a copy of the consent and offering to meet the client at appointments to support and follow up? Another person notes, I review notes in individual supervision. I inquire if they're building a contact list of provider connections. The expectation is that these relationships need to be built and nurtured. Another person writes, we discuss in team meetings, share experiences, good contacts, responsive providers. We role play. We support the care manager with one-to-one supervision. There are ongoing discussions about barriers. Other care managers share information about their experiences with various medical providers and what has worked and what hasn't. So here, people can really hone in on, since they're working with many of the same providers, they can learn from one another. It's often a part of a case presentation. It may or may not come up at that time, depending on the consumer's current life situation. One part is often care manager dealing with consumers' negative perceptions and experiences with the medical community. This is, I think, the second time we've heard that. Mm-hmm. We partner with the client to get and give information to providers as they're able and willing. Through supervision, hearing how these interactions are going, their successes and challenges, problem solving. We discuss different approach methods. Once again, what's working, what isn't. And checking on documentation. Let's see. Is the medical piece a part of the care plan? As a supervisor, I'm going to look at that.
Right.
And I see a number of other people talking about case reviews and progress notes and direct observation. We address it at team meetings.
Great. So Paul, if I could just recap here before we get to the next section.
Yeah.
What I'm hearing a lot of, and you can correct me if I'm wrong, but I'm seeing a lot of quality assurance work going on here. So they're looking at notes, they're reviewing it in team meetings, there's role plays taking place, but one of the things that I think is a great idea is sharing of best practices. So someone had a great experience with a medical provider. Can you use those interventions and what you did, sharing it with the team, maybe role-playing the discussion that you had with the practice manager? Those are all great things that you can bring to the table. And I think, those are great ideas that folks brought up.
A care plan due dates for all clients and follow up monthly with the care managers to make sure that case conferencing is happening. Thank you, Barbara. And I'm wondering, while people are typing up, how big a stretch this is for your care managers around interacting with medical providers. Have folks had experience doing this in the past, or is this a new set of tasks? Diana writes up, we keep stats on the number of medical contacts made per quarter for each member. That's wonderful. So you really can stay on top of up-to-date data. The care managers are expected to have interaction with the medical provider at least quarterly. Nice, so you've got a clear expectation. We review stats with the care managers to see if they are reaching out to medical providers. We follow up with staff meetings. So this is data-informed supervision at its best. Terrific, Diana. Thank you. Anything else people would want to share? Okay, I think we can move on.
Okay, so I think we're going to start with very similar, Paul, in the sense of looking at the hospital collaboration.
And so the question is, how do your care managers currently interact with hospitals? What do they do and with whom? And this is a question around psychiatric hospitals, but also around general hospitals and any other facility in your area. What are they currently doing, your care managers? Please take a few moments, type it up. Let's see what's going on. And we can also add to that the next questions, which would be, so what's going really well and what challenges are they facing as they relate to hospital staff? We'll give folks a couple of minutes. Please share what's going on so we can learn from each other. We have a comment from Sue. We have some notes that Nancy's sharing from last time. Let's see if anybody else has anything before we start reading. Okay, so Sue tells us our outreach coordinator meets with the clients that we receive referrals on from the health home while they are hospitalized. Nice. If they express interest in care management, then a care manager is assigned to them. So this is about connecting while people are in the hospital. Nancy has a note from last time, attend discharge planning meetings. Sounds like we're on the same wavelength here. Call to coordinate the case while inpatient, yes. Coordinate admission at the emergency room level. Sue tells us we have a system in place where the hospital notifies our health home and then they pass the referrals on to us. So that's really neat. Nancy shares from last time. Once we hear that our client has been hospitalized, the care managers contact the social worker. They visit with the client on the floor and meet with the client and social worker, reminding the social worker to keep the care manager involved in the discharge planning. Terrific. Diana shares that care managers are expected to call the social worker for the behavioral health admission as soon as they find out about an admission. Contact for the BHU is usually the social worker. For medical admissions, we try to make contact with the social worker involved as well. We have contacts at one particular hospital. Barbara adds, we are enrolling patients who have been readmitted to the hospital while they are still inpatient so that care managers can be a part of the discharge planning and follow-up care. So I think we're seeing different kind of riffs on the same message here, and that's about connecting real quickly when people are in the hospital.
Yeah, that's great stuff. And I think, you know, what it points to, again, is getting in early and getting in often. And I do like what some of the feedback that I saw in there in regards to having partnerships with the hospitals, because I think that's really key, Paul, when we're looking at sort of the role of the health home case manager and really what the state envisioned. New York State is really trying to make a coordinated effort to really prop up the health home role in the hospital workflow. And so what I mean by that is that what is coming down with all initiatives related to Medicaid redesign and some of the DSRIP initiatives is getting a coordinated approach in decreasing fragmentation, and who they want to do that is the health home case manager. That's a lot of responsibility, but I do believe that the state is really pushing in that direction. And here are some things that they would want us to do, and what they think is important is that if somebody's in the hospital, as you guys know, and you're lucky enough to find out, and I think as what was alluded in some of the responses, is that folks are creating those partnerships and getting connected to a discharge planner. A discharge planner is really critical, looking at the aftercare plan and making sure that that individual, based on what's going on with them, is getting their needs met. The other thing that might be helpful, let's say we found out that an individual is in the hospital and we weren't lucky enough to be a part of the discharge planning process. Well, what do? We ask for a discharge plan. Every hospital has one. Some might be pages long, some might be one page, some might, be still handwritten, some might be in the computer. We need to get a hold of that discharge plan, because what it's going to tell us is, how did they get there? And the number one reason for readmission within 30 days or otherwise is medication. People are not either taking their medications, or the medication that they're currently on is interfacing with another medication, which makes it counterproductive. So I think one of the things that we can do as health home case managers, or when we're supervising our colleagues, is really looking at, did you look at the meds that they were on before they went in, and did you look at the meds that they were on after they got in? I think that's very important to become more knowledgeable. It doesn't mean you have to be pharmacists or psychiatrists. It just means that you're looking at some big variation. I told folks time and time again when I interface with hospital case managers, health home case managers, one of the things that you can do if you're in the home is have the individual line up their bottles, all the medications that they're on, get out your smartphone and take a picture of them. Because you can take that picture and give that information to the provider or bring it to the provider. Most folks have a smartphone, and I think it's a great idea, because you would be surprised that some of the individuals that we interact with have very complex medical needs, and not all the providers, because again, they have a lot on their shoulders. I am not calling out providers. They have so many individuals maybe interacting with them on a specialist level, cardiologist, podiatrist, dental work, and they don't really understand the breadth of medications that somebody is on. So that might be one thing that you might want to do that could be helpful to the process. The other thing to really look at, again, back to medication being a huge factor in readmission rates, is how can you and does the individual have access to medication? Because I think that that is really important. You know, can they get to the pharmacy? Who gets their medications? A lot of folks have individuals that go pick up their meds at the pharmacy. Is that individual sick? Who is typically their support? Do they have a backup plan? Those are all things when you're going through a case management plan that can be helpful. So turn it over to Paul for the next question related to supervision.
Thank you, Peter. So the next question has to do with, how do you currently supervise your care managers' interactions with hospitals? What can we learn from you? And please give us concrete examples. So we'll ask folks to take a couple of minutes, type it up in the chat box. Please make sure you send it to all participants. So this question is around your care managers working with hospitals and discharge coordinators and others in the hospital setting. How do you supervise that? Do you do it individually? Do you do it in group? Do you ever go out in the field with them? Do you model? Do you role play? What are people doing? Please let us know. Well, people are typing up, Peter. I just want to underscore that same point again around the engagement process, this time with the hospital staff. You know, one key element is to find out and ask about, how as a care manager can I be helpful to you?
That's right. I think it's similar to the medical provider. Is one of the things that the health home case manager could do, Paul, is help with some of that burden and help with some of that. And that's really once individuals, medical providers, discharge planners see them as a resource, they will become their best friend. And that's a good thing. That is a good thing. We want them to call when individuals are struggling and going into the hospital. We need to work together to sort of get at what led to the readmission or the admission and how can we help them to prevent it.
Yeah. Yeah, I see Sue has typed up. How is she doing supervision around interactions with hospitals? Through individual supervision and team meetings. We discussed how to navigate the hospital system to best meet with clients' needs without disrupting the hospital staff too much. So it's how to go in there and not be a pain, but how to be a help.
Yep.
Then Diana writes up, we discussed this at staff meetings. We talked specifically about individual hospitals and the contact persons at each place. And I bet different hospitals have very different personalities and very different access points. So that's great that you're doing that. Some of the care managers may have a lot of experience at a particular hospital. One of our care managers who has a good relationship with the discharge team at one hospital has been able to relay information to the rest of us about who the discharge planners are and how to reach them. This is really teamwork. That's great, Diana.
That's a good model, very good model.
Anything else?
You know,
go ahead, Peter.
I think well, what it underscores really is, again, to not be a one-trick pony, as they say. You know, that we need to use all tools. And I appreciate the point of, you know, maybe it is divvying up, if you're in a larger community, divvying up sort of champions, health home champions at a particular hospital to be seen as a resource.
Yeah. Okay, I guess it's time to move on to the next topic area.
Great.
So
now we're going to talk about MCOs. Go right ahead.
Yeah, so managed care organizations, very important, now more than ever. So how do your care managers currently interact with managed care organizations in your area? What do they do? And we can carry it over to and what's going well and what are the challenges. So first we talked about, primary care providers. Then we talked about hospitals. Now we're talking about the managed care organizations. So what are your staff doing? How's it working? What's not working? Please take a couple of minutes and share what you can. And Peter, as we're waiting, I think I want to return again to that same issue again around engagement and finding out how, as care managers, we can be helpful to the MCOs. That question of, so what can I do for you, is just so critical.
Well, and I think as folks are typing here, Paul, I think one of the things that we emphasized in the last two presentations that I've done on this particular topic, and really cannot be overlooked, is we can help the managed care companies with quality. And that's important to them and the quality of care that they provide, because the state rewards managed care companies for having the individuals that they provide services for get into the care that they need. So that's a real key piece that we can't forget.
Yep. Sue types up here, are care managers and outreach worker as a staff member at the MCO that they contact for updated addresses, phone number information. Care managers also have a contact at the MCO should they need to assist the client with getting certain services approved. You can see where the communication in this case is really, begun to come together nicely. And Nancy shares from last time, one local hospital was willing to embed care managers and positive attitudes. We are piloting a transition schedule for our care managers in order to have a 24-hour response time to RHIO alerts and discharge, and that is working well.
Excellent.
Embedded care managers within the local hospital, nice. Diane shares, we have not had as much contact with the MCOs as with the hospitals and others. We have been contacted by MCOs more, and as soon as we hear from them, we follow up. We are in process of increasing communication. And then Nancy sharing challenges from last time. Some hospitals think it's the care manager's role to come up with a discharge plan, especially where housing and homelessness is the issue. Not letting the care manager know when discharge is happening. We've been hearing some of that. Patients being discharged without notice. Care manager find out after the fact. Coordination with the emergency room on medical issues. The biggest issues we have with all of this and doing the job well is time to do everything that should be done. Many players in the hospital setting and staff changes make it difficult at times to find the right person to discuss a client with. Anybody else have any other thoughts about the MCOs before we move on to a little bit more presentation from Peter? Okay, back to you, Peter.
Great. Okay, so how can the MCOs help me? Well, one of the ways, I think someone had mentioned workload, and I certainly appreciate that, that's for sure. And I know that a big emphasis with Health Home is outreach, finding individuals. An MCO can help. And they can help because they, what do MCOs do the most? They process claims. And on every claim, there has to be not only a name and a date of birth and a Medicaid number, there's an address typically tied with that. So if you have somebody, or a phone number, So I would try to figure out, can I get a resource in the MCO who can help me get some of that information? I think someone mentioned that, is that I know that some of the MCOs have started to actually share who is involved with their internal, meaning the MCO has case management services, who's involved, who's on their radar, and they give the most up-to-date address and phone number. Again, that might be a way to assist you in locating individuals that are difficult to find. The other two that I had down here that makes sense is access and network. And what I mean by that is a lot of times what I hear is that that's great that you want them to go see a medical provider or primary care physician. Primary care physician, I call them, I tell them I'm a new patient, and it'll be 3 months before I get a visit. Well, the MCOs can help with that. What we need to do is to work with them because they have network standards that they can't put out appointments for 12 months, and we need to push back and have individuals really advocate for themselves using the supports within the MCO, member services, to really to tell their story. They've been trying to get a PCP visit. Someone is, 12 weeks out. Can you help me? That is what they're supposed to do. That is what the state pays them to do. So I think it's very important in those two areas with outreach and access. These are issues that are very important to the MCOs and to the health home case manager. So let's, utilize member services for the MCOs and make sure that they know you're out there trying to get what you need. Some other things to consider when it comes to an MCO is a lot of the MCOs have case management programs. So they already have tools in place that identify individuals that they want to outreach to. And depending on the MCO, depends on the intensity level. Some MCOs actually have folks that go out to the home and interface with individuals. Some MCOs just do telephonic case management. Some just send information. So I would, if I was the supervisor, with some of the managed care plans, get a sense of, do they have a case management contact internally? The other thing that MCOs are really good at, and they can offer to individuals, is information on specific disorders. So if you go on to any MCO website, they will have a section, every MCO will have this, trust me, and it's pretty easy to find, especially if you Google. They will have information on any chronic condition. Again, this is a mandate that they have to do certain quality standards for the state and federal guidelines. So if I am with Blue Cross Blue Shield and I find them in my region and I type in diabetes management into their website, you will be pointed to something that will identify resources and information on diabetes. So again, that is another tool that you can give individuals if they want it. And a lot of the information I find, depending on the individual, just like anything else, it's out there. It's just a matter of, is it going to be helpful to the overall progress of the individual moving forward? So something to think about. They have a lot of information, and they might already have a case manager involved.
So
we're wrapping up.
Yeah, we have one last question around supervision. For those of you who have been supervising your care managers interacting with managed care organizations, I don't have a good feel right now for how many folks that might be. Same questions we've been asking before. How's it going? What can we learn from you? And specific focus supervision around relating to managed care organizations. So if anybody's had that experience, if you can take a couple of minutes and type it up, please, as this is probably, I think, the last question related to your supervision for today. And Peter, as we're waiting, I think, one of the things that we're learning and that we've observed is that, for many of the care managers who had been case managers in the more traditional kind of behavioral health care and mental health programs, there are all these new cultures they need to learn about. And one of them certainly is the whole, primary care world. But another one, and a very different culture, is the culture of managed care organizations. And to the extent that supervisors can themselves become familiar with that culture and help their staff to become comfortable with it, that's going to be a great thing.
I agree, and I think one of the things that MCOs bring to the table that I mentioned before, Paul, is data. That's how they can be helpful. So if you're struggling to find somebody or you're trying to figure out, what providers are involved with individuals, it really is upon the MCOs to help coordinate that and get you that information.
Good to know. I'm not seeing anybody type up, so maybe we can move on.
That was the last question there, Paul, moving forward. So I guess what I would suggest folks do in regards to the, just sort of wrapping up, when we look at navigating with medical providers, hospital providers, and MCOs, as you suggested, Paul, the skill set really calls upon building relationships with these organizations. And one of the ways that you can start doing that is to start getting a list of contacts within your region. And I know that one of the ideas that has been floated around, which makes sense to me, is with all the Medicaid redesign initiatives, can we set up collaborative meetings with a lot of these partners, even quarterly, semi-annually, just to see how things are going? Because as with any relationship, you can start off on how we can be helpful to you, you can engage them, but then the key piece is how can we continue that relationship so it makes sense moving forward? And I think that would be something that I would put out to your colleagues in the health home arena. And the other thing that I would emphasize is to make sure that you're involved with any of the DSRIP initiatives within your area, because the state calls out in each one of the DSRIP reform initiatives the role of the health home. So those were a couple of ideas that I think would be helpful to the group. Do you have anything to add, Paul?
No, I think you really hit it on the head. Other than to thank everybody for joining us today. We really do appreciate it.